Welcome to the training on the Continuity Assessment and Record Evaluation, also known as the CARE tool. This training was originally developed by the American Healthcare Association and the National Association in Support of Long-Term Care for their joint work group to measure therapy outcomes. AHCA and NASL gave permission for Optima Healthcare Solutions and Rehab Resources and Consulting to update the training materials, so it could be used by a larger part of the rehabilitation industry who is interested in finding an outcomes tool that will enable them to measure and improve upon rehabilitation outcomes. This is the third of 3 trainings in the series. In order to make your training session more meaningful, you should have with you the CARE Item Set Training Manual. Within this manual is a lot of helpful information. The CARE item rating definitions to be used for the mobility items can be found on page 3 and 4. A chart that defines each CARE mobility item, as well as each CARE rating for that mobility item, can be found on pages 14 through 28. At least 2 or 3 clinical vignettes for each CARE mobility item to illustrate how the ratings would be applied in a clinical setting can be found on pages 38 through 55. Finally, you will be required to take the CARE item post-test. This will test your knowledge of the material presented. Why is this training necessary? The training and test ensures that you, the therapist, understands what each CARE item includes and does not include. As therapists, we may have different ideas about what is included in the task of chair-to-chair or bed-to-chair transfers, or in the task of picking up objects. This training will define exactly what functions the mobility tasks or items include so we can all measure the same thing. The training will also provide each therapist examples and a clinical algorithm to use when scoring each item. It is important to ensure that each person using the tool understands the definition of the CARE mobility items and how the CARE rating scale applies to each item. Because everyone is receiving the same training, the ratings are more consistent. It also ensures the data collected is consistent. One of the project's goals is that we can begin to assemble a database of information across companies and across the nation so that we can truly measure clinical outcomes for our patient populations. This first step in accomplishing that goal is to have consistent item sets and consistent measurement scales. It is worth repeating that even if a particular task or activity is not going to be the focus of your therapy program, you still must score those items. The CARE item scores add up to be a composite score of the patient's overall function. So if items are left not scored, then the patient's overall level of function in self-care and mobility will be lower than they should be. When we score tasks and items as NT, or not tested, or NA, not applicable, we downplay the role we have on a patient's overall level of function. So while we have alpha scores for those times where it is just not appropriate to assign a numeric score, please keep in mind that these codes should be used minimally. You see on this slide and on page 5 of your training manual the list of 15 items that make up the CARE item mobility set. The first 3, lying to sitting on the side of the bed, sit to lying, and rolling, are subtasks of what many of us might think of as bed mobility. Items 4, 5, and 6, sit to stand, chair, bed-to-chair transfers, toilet transfers, and car transfers, are components of what many of us might think as transfers. Item 7, longest distance walked, longest distance wheeled, and items 11 and 12, walking 50 feet with 2 turns and 10 feet on uneven surfaces, are components of what many of us think as locomotion. And finally, items 9, picking up an object, 13, 14, and 15, about going up and down steps, are higher level mobility items that are helpful in determining someone's ability to perform at a higher functional level, perhaps in the community. The general format of this training will include going over a description of the task, followed by the rating scale for the items, followed by some examples of applying the rating scale to the item, but also keep in mind that there are additional clinical vignettes for each of these tasks in your manual for reference, but we won't be going over all of those today in the training module. The first care mobility item is lying to sitting on the side of the bed. This item is defined as the ability to safely move from lying on the back to sitting on the side of the bed with feet flat on the floor and no back support. This item is not about returning to lying down, because that is covered in another item. Because there are many steps to completing the task of lying from flat on the back to sitting on the side of the bed with the feet flat and no back support, it is important to keep all those parts of the task in mind when determining whether you are giving more than 50% or less than 50% assistance. On the other hand, touching, steadying for balance, or to guide a limb all the way off the bed may only be needed rather than actual physical assistance. Also keep in mind that equipment does not matter in choosing the rating, so the patient may use assisted devices such as side rails, grab bars, or even elevation of the bed. This is an example of the rating chart in your training manual for lying to sitting on the side of the bed. The tables are all oriented the same. In the first column on the left-hand side will always be the description of the task. In other words, how is it defined and what subtasks are included. The next 6 columns correlate to each of the rating levels. Each column represents one of the 6 care item ratings, and their definitions are repeated in bold font for each item. In each column are examples of when that rating might be applied to the task. Examples of clinical application that might qualify for that rating are listed, but keep in mind it is not an exhaustive list. You may encounter situations that are not listed here, so it's important to always use your best clinical judgment. So what would a rating of 4 potentially look like for lying to sitting on the side of the bed? If a patient requires prompting and cueing for sequencing to fully accomplish safely moving from lying on the back to sitting on the side of the bed with no back support, then 4 would be the best choice. Or if the helper must verbally guide the patient in completing the task and/or provide touching, steadying assistance to the patient completing the task without falling over. Or touching or steadying only may be required for hand placement, initial sitting balance after fatigue, and/or pelvic stability for sitting without back support. Let's look at example number 1. Mr. B pushes up on the bed to get himself from a lying to a seated position. The helper provides steadying assistance as Mr. B scoots himself to the edge of the bed and lowers his feet to the floor. What is the care rating level for Mr. B? The best choice is 4, supervision or touching assistance, because the helper provides touching assistance as the patient moves from a lying to a sitting position. Example number 2 is Mrs. W. She can reach for the bed rails and initiate pulling herself to her side. She can initiate raising one leg in an effort to use her leg to push herself over, but she requires assistance from the helper to roll over. Once she is on her side, she requires the helper to raise her up to a sitting position. She can sit upright with steadying for less than 1 second at a time and requires full assistance otherwise to remain upright. What is the care rating level for Mrs. W? The best answer is 2, substantial or maximal assistance. The patient attempts to participate in the activity, but the helper provides more than half the effort to complete the task. The next item is sit to lying. It is defined as the ability to move from sitting on the side of the bed to lying flat on the bed. This item is not about moving from lying down to sitting up. We just covered that in the last item. A coding tip to remember is always think of usual performance, not the lowest or the best. And once again, the patient can use assisted devices such as side rails, grab bars, or bed elevation. The rating scale for sit to lying is on page 15 of your training manual. As described before, the column on the far left defines the item. The next 6 columns correlate to each of the rating levels. So let's look at the description of rating 2, substantial, or maximal assistance, which is when the patient participates but provides less than 50% of the effort to complete the task. So you might have a patient who is able to initiate the movement by reaching for the bed rail, lowering themselves to the elbow, or partially lifting their legs toward the bed, but is unable to initiate a significant physical effort at moving to a lying position. The patient requires greater than 50% assistance from the helper to get the legs on the bed and in a fully flat position. Or the patient is unable to initiate positioning themselves for getting to a lying position, but once the movement is started, the patient is able to lift one leg partially or even completely onto the bed. Or maybe the patient is unable to contribute to moving from a sitting position to lying on the side or lift the legs on the bed, and the helper provides greater than 50% of the effort. But once the patient's legs are up on the bed, the patient can roll to their back. Let's look at example 1. Mrs. H requires assistance from a helper to transfer from sitting at the edge of the bed to lying in bed due to paralysis on her right side. Mrs. H can use the bed rail to lower herself down to the bed, but cannot lift her legs completely up onto the bed. The helper lifts Mrs. H's legs and assists her in positioning them. Mrs. H then uses her arms and upper body to position her trunk. So what is the care rating level for Mrs. H? The best choice would be 3, partial or moderate assistance. A helper is needed to transfer from a seated to a lying position, but Mrs. H does the majority of the task. Example 2 is Mr. A. He is wearing a shoulder immobilizer after fracturing his humerus. He is able to walk around his room and transfer to the side of the bed. In order to lie down safely and with the least amount of pain, he asks the helper to raise the upper bed rails and the head of the bed for him so he can use it to assist himself lying down. What is the care rating level for Mr. A? The best answer would be 5, setup or cleanup assistance. A helper is needed to prepare the bed for Mr. A by putting the rails in the optimal position. This would be considered setup help. The next item is rolling left and right. It is defined as the ability to roll from lying on the back to the left and the right side and then return to lying on the back. This item is not about sitting up or lying back down. A few tips again. With this item, the patient may use assisted devices. The rating scale for rolling left and right is on page 16 of your training manual. The difference between a rating of a 4 and 5 for this item is again the difference between providing help during the activity versus before and after. When a patient needs prompting or cueing during the task, then the rating becomes a 4. But if the patient only needs the helper to help them before or after the task, such as placing hands on a bed rail or positioning a leg, maybe removing the bed covers so the patient can move more easily, then the score would be a 5. Remember that if the application of a prosthesis or orthosis is necessary to complete the task, this is not considered in the score for rolling. If the helper is needed to do this, it is considered setup only. Let's look at example number 1. Mr. W is able to reach for the right bed rail with his left arm and pull himself over to sideline without assistance from the therapist. With cues, he is able to roll back to supine. With assistance, he can pull his right leg to a hip-knee flexion position and initiate pushing himself over to his left side, but needs cues to cradle his right arm, and is not able to reach full sideline without assistance from the helper. What is the care rating level for Mr. W? The best answer would be 3, partial or moderate assistance. The patient is able to roll to one side without assistance from the helper, but requires verbal cueing to return to his back and physical assistance to roll to the other side. Overall, the helper is providing less than half the effort, and therefore the patient is coded as 3, partial moderate assist. Let's look at example number 2. At discharge, Mr. W., the same patient, is able to reach for the right bed rail with his left arm and pull himself over to sideline without assistance from the therapist. When prompted, he is able to roll back to supine. With prompting, he can pull his right leg to a hip-knee flexion, but requires assistance from the helper to stabilize the leg while he pushes himself over to his left side. He still needs cues to cradle his right arm due to his residual neglect. He is able to return to his back without assistance from the helper. What is the care rating level for Mr. W now? The best choice is supervision or touching assistance. The patient is able to roll to one side without assistance from the helper and requires verbal cues and steadying from the helper to roll to the other side. He is able to return to his back without assistance from the helper. And remember, there are more examples in the training manual. The next item is sit to stand. It is defined as the ability to safely come to a standing position from sitting in a chair or on the side of the bed. This item is not about sitting back down. So keep in mind a few tips. The patient may use assisted devices, and the helper should consider preparatory steps, such as whether assistance is needed with scooting to the edge of the bed or chair, or weight shifting forward. And as always, consider the patient's usual performance, not the lowest. The descriptions for this item can be found on page 17 in your training manual. When scoring, consider all the elements of standing from a sitting position when considering the greater than or less than 50% assistance. For instance, a rating of 2, substantial maximal assistance, might look like the patient is able to complete steps such as scooting forward to the edge of the chair or positioning their legs and feet for weight bearing, but they still require physical assist to stand. Or the patient cannot do any of the preparatory steps, but once they are in position, they can generate some force in standing. Let's look at example number 1. Mrs. D arrives to the therapy gym in a wheelchair and is ready to start gait training with her new prosthesis. The therapist assists her by putting on her new prosthesis and positions the wheelchair in front of the parallel bars. Once in position, Mrs. D stands up from the wheelchair and steadies herself on the parallel bars. What is the care rating level for Mrs. D? The best answer is 5, setup or cleanup. The helper assists Mrs. D with getting ready to stand by positioning the wheelchair in front of the parallel bars and putting on her prosthesis. Mrs. D is able to stand up by herself after getting set up. Example number 2 is Mr. M. He gets from a sitting to a standing position. The helper touches his arm to steady him. The best answer for Mr. M is supervision or touching assistance, because that is the only assistance the helper provides. The next item is chair to chair or bed to chair transfers. It is defined as the ability to safely transfer to and from a chair or a wheelchair, but the chairs are placed at right angles to each other. This item is not about walking a short distance to a chair, so the instructions that the chairs are at right angles to each other is important. Keep in mind the patient can use assisted devices and usual care should be considered. So it might be beneficial to assess the patient in transferring to and from several surfaces and surface heights, such as mat tables, wheelchairs, bedside chairs, those with and without armrests. And as always, consider the patient's usual performance, not the lowest. This is an activity especially where patient's performance might vary over the assessment period, depending on the patient's fatigue level. If you are assessing a patient over the course of an hour, or even during a morning and afternoon session, the patient may become more fatigued during that time. So you should use your clinical judgment to determine what the usual performance during that assessment period is. The rating scale is on page 18 of your training manual. A patient would be best scored as 3, partial or moderate assistance, if they could participate in rocking forward or scooting to allow a sliding board or disc to be placed underneath them. or perhaps they leaned forward to assist with weight shifting. Perhaps the patient can scoot forward to the edge of the bed or the chair and position their own feet. Perhaps they can even place the sliding board underneath themselves. Or maybe they are unable to complete any of these preparatory steps due to cognitive or aphasia reasons. But once they are in a position, they can provide some of the effort to move their body weight in the transfer. Let's look at example number 1. The helper is providing lifting assistance as Mrs. Z moves from the bed to a chair. Mrs. Z provides some effort during the transfer, but the helper provides more effort than the patient. What is the care rating for Mrs. Z? The best rating for this patient is a 2, substantial or maximal assistance, because the helper provides more effort than the patient. In example number 2, Mr. L had a stroke 3 days ago and uses a wheelchair for mobility. When Mr. L gets out of the bed, the helper moves the wheelchair into the correct position and locks the brakes so that Mr. L can transfer into the wheelchair safely. Mr. L transfers into the wheelchair by himself about 10 minutes later. What is the care rating level for Mr. L? The best rating for this patient is 5, setup or cleanup. The helper provides setup assistance, but Mr. L does not need help during the transfer. The next item is toilet transfers. It is defined as the ability to safely get on and off a toilet or commode. Note that this item is not about hygiene associated with toileting, nor is this item about managing clothing off or on. Only the transfer on and off the toilet should be considered. Depending on the patient and the circumstances, a patient may have different performance getting on the toilet versus getting off of it. So again, it's important to consider usual performance. A few tips for scoring are to remember the patient can use assistive devices. The rating guide is on page 19 for toilet transfers in your manual. For this item, a rating of 5 would be given if the helper assists with preparing the patient for the transfer, perhaps by pushing the wheelchair to the toilet or locking the wheelchair or removing leg rests or arm rests. Or, if the patient wears an orthotic or prosthetic, they may need help in donning or doffing it prior to the transfer or after. As we've mentioned before, how much assistance the patient needs in donning and doffing the prosthesis is not a factor in choosing the score for this item. Let's look at example number 1. A helper provides hand-on assistance to steady Mrs. Z as she lowers her underwear and pants and then lowers herself onto the toilet. After voiding, Mrs. Z cleanses herself. She then stands up and pulls up her underwear and pants as the helper steadies her with her hand placement on her back. What is the care rating level for Mrs. Z? The best response is supervision or touching assistance. The helper provides steadying assistance as the patient transfers on and off the toilet. Assistance with managing the clothing and cleansing is coded under the item toilet hygiene. In example number 2, Mrs. S is ordered to stay on bed rest. She is able to use a bedpan independently for bladder and bowel management. What is the care rating level for Mrs. Z? The best response is dependent, because the patient does not transfer onto or off a toilet due to an order to remain on bed rest. And this item is specifically about transferring on and off a toilet, not a bedpan. The next item is longest distance walked and or wheeled. These items require the therapist to determine whether one type of locomotion will be a goal or whether both types will be. If only one type of locomotion is a goal, then that is what is included in the composite score. But if both types of locomotion are goals, then the scores are merged into one score that goes into the patient's total mobility score. The therapist should complete both items if the patient achieves locomotion by walking and using a wheelchair, or the patient currently uses a wheelchair and does not ambulate, but ambulation is a goal of the therapy plan of care, or the patient currently ambulates and does not use a wheelchair, but using a wheelchair is a goal of the therapy plan of care. So if a patient does not use a wheelchair, and it is not going to be a goal of the therapy plan of care, the patient only ambulates, then score the longest distance wheeled as in or not applicable. Conversely, if the patient does not ambulate, and it is not a goal of the therapy plan of care, and the patient only utilizes a wheelchair, score the longest distance walked as in or not applicable. The next step is to score the mobility distance, and this is a two-step process. First, observe the longest distance walked or wheeled. Choose the response that best describes the longest distance the patient was able to accomplish, ranging from 10 to 150 feet. Then secondly, rate their level of independence with a scale of 6 to 1 only on the distance they achieved. That is important to remember. You are only scoring one distance, not all of them. So let's look at the longest distance walked item first. The item is defined as, once standing, the patient's ability to walk greater than or equal to 150 feet, or greater than or equal to 100 feet, but less than or equal to 149 feet, or greater than or equal to 50 feet, but less than or equal to 99 feet, or greater than or equal to 10 feet, but less than or equal to 49 feet. This item is again not scored if the patient currently does not walk and is not expected to walk. You also do not consider the patient's ability to stand up. The level of assistance is recorded for the patient's ambulation ability only. A few tips, because this item may be different than what you are accustomed to scoring, because only one distance is scored. If the patient is unable to walk 10 feet, then they are scored as dependent, even if they were able to walk 5 feet with steadying and touching assistance only. The score for 10 feet, which is the minimal choice, is still dependent. Why? When the CARE tool was being designed, there was a significant effort given to standardizing items so they could be used across all post-acute care settings. In other words, home health, skilled nursing facility, inpatient rehab, and long-term acute care hospitals. Therefore, the items needed to be constant. There was also discussion about the fact that distances needed to be meaningful. While meaningful can be defined in different ways, for this item, consideration was given to what the assessment tools in our settings currently are and what the current literature tells us about measuring locomotion. So a few facts filtered to the top. Some items used currently consider whether a patient could walk across a room. And walking speed is a very significant measure in physical therapy, is measured by having a patient walk 4 meters, which is the equivalent of approximately 13 feet. For these reasons and others, the minimal distance to be measured is at least 10 feet. The distance measured increases incrementally after that. This algorithm is also on page 20 of your training manual. Essentially, you should determine the best score using these steps. First, ask yourself, how far did my patient walk? Then ask yourself, how much assistance did they require? So if your patient walks less than 10 feet, then you are done. Your score is dependent, or a 1 for walking in room or greater than equal to 10 feet, because the patient did not walk 10 feet. But if your patient walks 45 feet on evaluation, your distance would be scored for walking in room or greater than equal to 10 feet. The next step is to choose your level of assistance. Focus on the usual level of performance, even over these walking distances, when their performance or level of assistance required is variable. You might have a situation where a patient is independent walking at 50 feet, but maximum assistance walking at 75 feet due to pulmonary issues. The patient therefore self-limits himself for the 50 feet because that is the distance he needs to be able to travel in his home. The final score would be independent at 50 feet because that is his usual performance. Now, this type of scenario would be unusual and infrequent, but it is the correct scoring for that situation. Also remember that assistive devices do not matter for this item. So take the same patient who uses a walker to ambulate 50 feet at admission independently. At discharge, the patient no longer uses any assistive device and is able to walk the 50 feet independently. Your score is going to be independent 6 at admission and independent at discharge. That might not feel right to you as a clinician, but it is the correct scoring methodology for this care item tool. Let's look at example number 1. A helper puts Mrs. W's walker within reach. Mrs. W needs verbal cues to remind her of the safest way to stand up from a sitting position. Once standing, Mrs. W walks 120 feet down the hall without any assistance from a helper. What is the care rating level for Mrs. W? The best response for distance is 100 feet, but less than or equal to 149 feet. The best answer for level of assistance is setup or cleanup. Mrs. W walks more than 100 feet once the helper places the walker within reach. She needs assistance with getting up from a sitting to a standing position, but that is coded under the item sit to stand. This item only considers walking after the patient is standing. Example number 2 is Mr. C, who is 1 week status post left hip fracture. He has non-weight-bearing orders for his left leg. He's brought to the therapy gym for gait training, but he is able to use the parallel bars to pull up and requires only minimal assistance to stand. Once standing, he is able to hold the left leg off the floor, but he is unable to hop in the parallel bars due to his upper body weakness and coordination with understanding non-weight-bearing. What is the care rating level for Mr. C? The best response is distance walked, walk in room, or greater than equal to 10 feet, and the level of assistance is dependent. Mr. C is unable to keep non-weight-bearing status, and therefore he is unable to walk at all. But the minimal distance that you have to choose from is 10 feet. The next item is longest distance wheeled. The same clinical analysis should be used with this item that was used with walking. It is defined as, once sitting, the patient's ability to wheel greater than or equal to 150 feet, or greater than or equal to 100 feet but less than or equal to 149 feet, or greater than or equal to 50 feet but less than or equal to 99 feet, or greater than or equal to 10 feet but less than or equal to 49 feet. This item is again not about how the patient gets in and out of the wheelchair. It is also not scored if the patient does not currently use a wheelchair and is not expected to use a wheelchair. As with the walking item, this item may be different than what you are accustomed to scoring, because only one distance is scored. And if the patient is unable to wheel 10 feet, then they are scored as dependent, even if they were able to wheel 5 feet with steadying or touching assistance only. The score would still be dependent for 10 feet. This algorithm is on page 21 of your training manual. Essentially, you should determine the best score using these steps. Ask yourself, how far did my patient wheel? Then ask, how much assistance did they require? So, if your patient wheels less than 10 feet, you are done. Your score is dependent, or a 1, for wheeling in room or greater than or equal to 10 feet. But if your patient wheels 55 feet on evaluation, then your distance would be scored for wheeling greater than or equal to 50 feet up to 99 feet. The next step then would be to choose your level of assistance. Consider the previous example. A patient is able to wheel 55 feet. He or she can place their hands on the wheels and push themselves for part of the distance, but they need the helper to get started. Or perhaps the helper is needed to get around a curb or through the door. In other words, the helper is providing some effort to help them propel the wheelchair forward. Both of these situations would be scored with partial or moderate assistance. Of course, the therapist would need to determine whether the amount of assistance provided over the entire task was greater than or less than 50% of the effort needed for the task. Let's look at example number 1. Mrs. M is unable to bear any weight on her right leg. After the helper provides steadying assistance to transfer from the bed into the wheelchair, Mrs. M propels herself about 120 feet down the hall using her left leg. What is the care rating level for Mrs. M? The best response is wheeling 100 feet but less than or equal to 149 feet, and the level of assistance would be independent. The patient wheels herself more than 100 feet but less than 150 feet. The assistance provided by the helper with the transfer is not considered when scoring longest distance wheeled. There is a separate item for scoring bed-to-chair transfers. Let's look at example number 2. Mrs. P is 3 weeks status post right CDA. She is able to provide less than half the effort to transfer into the wheelchair. Once she is sitting upright, the helper removes the right leg rest and instructs Mrs. P in how to use her right arm and right leg to propel the wheelchair. Mrs. P is able to move her right leg forward and initiate pulling her wheelchair forward, but is unable to move the chair without assistance from the helper. What is the care rating level for Mrs. P? The best response would be wheeling in room greater than or equal to 10 feet, and the level of assistance would be dependent. The patient is able to provide some effort to wheel her chair, but is unable to wheel herself more than 10 feet. Therefore, the patient's score is dependent, and you would choose the lowest option available for distance. The next item is picking up an object. It is defined as the ability to bend or stoop from a standing position to pick up small objects such as a spoon from the floor once the patient is in a standing position. Many of the usual and customary assessment tools used by providers in skilled nursing facilities do not include this item. It does represent a higher level of function, and that is one of the main reasons it was included. It goes beyond just walking, transferring, and basic ADLs. But this item is not about how far away from the foot the patient can reach. So a few tips for scoring. Use an object that is easy to grip and easy to see. You can place the object in front of or to the side of the foot. Some therapists may not want to test this item on evaluation if the patient has significant balance deficits or requires substantial assistance to stand up. But remember, in those cases, the item would not be scored N, or not applicable, or even S, not attempted due to safety reasons. The more appropriate answer would be 1, or dependent, since it can be inferred from the patient's standing ability and the rest of your assessment that the patient is unable to do this task. The rating guide is on page 22 in your manual. For this item, a rating of 4 would be given if the helper needs to provide prompting or cueing to sequence the activity safely, as if the patient is bending or stooping over, or if the helper has concerns about safety with completing the task, and the therapist needs to remind the patient of some orthopedic precaution. Perhaps the helper needs to study the patient at some point during the task or throughout those tasks. All of these would result in a score of 4. Let's look at example number 1. Mrs. W keeps her reacher beside her at all times. Using her reacher, she can pick up her slippers off the floor to put them on. What is the care rating level for Mrs. W? The best response is independent. Mrs. W is able to pick up objects from a standing position using her reacher. The use of adaptive equipment does not decrease her score. Example number 2. Mr. G stoops down from a standing position to pick up the newspaper from the floor. He requires physical support from the helper to stoop down without falling over. Mr. G can pick up the newspaper, but he is unable to get fully upright again without physical support from the helper. What is the care rating level for Mr. G? The best response would be substantial or maximal assistance. Mr. G is able to pick up the object from the floor, but cannot stoop down or stand back up without physical assist from the helper. So the helper is providing more than half the effort to complete the task. The next item is car transfers. It is defined as the ability to transfer in and out of a car or van on the passenger side. This item is not about opening or closing the door or about fastening the seatbelt. So a couple of tips. Once again, the patient may use assisted devices. A back seat could also be used to test the item, and usual performance is important. The rating guide is on page 23 for car transfers. For this item, a rating of a 3 would be given if the patient participates in stooping, bending, or turning to get in position for the car transfer, and the helper provides less than 50% of the effort. Or perhaps the patient is able to stoop, bend, or turn and get most of the way in, but the helper still has to provide less than 50% of the effort to transfer in and out of the car. Or the patient can complete most of the steps to transfer in and out, including swinging his or her legs in and out. Once the patient is turned with the feet on the ground, he can use assisted device or car support to initiate most of the force to stand up from the car seat, but the helper still needs to provide less than 50% of the total effort to get the patient out of the car. Let's look at example number 1. Mr. D has a doctor's appointment to which his wife is going to transport him. He ambulates to the car with supervision or touching assistance using his walker. He turns around with his back to the car seat, but is unable to rotate his trunk and head around without losing his balance. The helper assists Mr. D to bend and lower his body into the car seat. Once he is seated, Mr. D is able to pick his legs up and put them in the car. When he returns from his appointment, he can swing his legs out of the car, but is unable to stand without physical assistance from the helper. Once standing, he is able to ambulate into his house. What is the care rating level for Mr. D? The best answer would be 2, substantial or maximal assistance. He is unable to stoop, bend, or turn to get in the car without physical assistance. However, once sitting, he can get his legs into the car, but upon return, he is unable to stand up, and the helper provides greater than 50% of the effort. Example number 2 is Mr. G, who has diminished vision. He is able to walk to the car using his cane. The helper lets him know when he is close enough to the car to step in. Before getting out of the car, the helper lets him know what the ground surface is like and hands him his cane. What is the care rating level for Mr. G? The best response is setup or cleanup. The patient is physically able to get into and out of the car. The helper only verbally assists him with preparatory activities due to his poor vision. The next item is walking 50 feet with 2 turns. It is defined as the ability to walk 50 feet and make 2 turns once standing. The task can best be described by having the patient walk 25 feet, turn to face the opposite direction, walk 25 feet back, and then turn again to face the other direction he started in. While there are no hard and fast rules in the care tool about how far to walk before turning, the 2 pieces of this task must be met, 50 feet and 2 turns. However, this item is not about the ability to stand up or sit down. The patient can use whatever assisted devices he or she wishes, and again, if the patient does not ambulate and is not expected to ambulate, this item would be in. But if the patient does not ambulate at evaluation, but it is a goal, this item would be rated as 1 or dependent. This item is important to assess, if possible, so marking off 25-foot distance is an important preparatory step for the therapist. You will want to clearly indicate where the turning point is for the patient, either by using a brightly colored piece of tape on the floor or a brightly colored cone. Be sure the patient has enough room to comfortably make the turn so they don't feel cramped. The rating scale is on page 24 in your manual. For this item, a rating of 5 would be given if the patient only needed the helper to prepare them for the task, such as by positioning the assisted device in reaching or applying a special shoe or orthotic or prosthetic. Example number 1 is Mrs. F. She is able to stand with maximal assistance. Once standing, she is able to walk 10 feet with less than 50% assistance from the helper. What is the care rating level for Mrs. F? The best response is dependent. The patient is able to ambulate but cannot walk 50 feet. The maximum distance she was able to walk was 10, which was less than the amount required for this item. So the best rating is dependent. Example 2 is Mr. W, who ambulates 25 feet, turns, and walks 25 feet back to his chair and sits down. The patient is unsteady on the turns, and the helper provides touching to steady him due to some loss of balance when weight shifting. What is the care rating level for Mr. W? The best response is supervision or touching assistance. The patient is only unsteady on the turns, and that's when the helper provides touching to steady him. The next item is walking 10 feet on uneven surfaces. It is defined as the ability to walk 10 feet on uneven or sloping surfaces, such as grass or gravel. This item, however, is not exclusive to outside terrain, so you should consider thresholds, carpeted areas, or even buy a piece of turf or carpet to lie down on the floor. Of course, it is easier outside with gravel and uneven sidewalks. It may be challenging to some to consider doing this task at evaluation, but remember that we should attempt to test the patient on all items. Don't assume the patient can't do it until they have tried. Keep in mind that on the uneven surfaces, the patient does not have to turn. It is just 10 feet on a straightaway. The only other aspect of the task to consider is the use of assisted devices. We know that some devices are not made for uneven surfaces. In the past, a therapist might have coded this as NT because of the equipment issue. But again, it is important to consider the concept of dependence. If the patient has to use a rolling walker, because that is what is safest for them, and the rolling walker is not going to be able to roll over large gravel, then the patient would be scored as dependent. Because if the only route the patient could get out of a building is over large gravel, then he or she would be dependent on a helper to get them out. That is the concept we are rating. If the patient is unable to walk on grass with their rolling walker because they are non-weight bearing, then they are dependent. The rating guide is on page 25 in your manual. Once again, remember the key difference between 2 substantial or maximal assist and 3 partial and moderate assist is whether or not you conclude that less than or greater than 50% assistance was provided to the patient during the entire activity. Consider subtasks, such as whether the patient can advance the assisted device with or without assistance, whether the patient needs assist to bear weight, whether the patient needs assist to balance him or herself, whether the patient needs assist to having enough power to get up a slope, if that is what the uneven ground is, or if the patient has weight-bearing restrictions, whether they are able to manage the 10 feet on uneven surfaces without any assistance. Let's look at example number 1. Mr. B ambulates up to 25 feet on uneven surfaces with partial or moderate assistance from a helper. His front walkway to the car is gravel. Mr. B can manage 5 feet on the gravel, but then decompensates such that he must sit down. What is the care rating level for Mr. B? The best response is dependent. The patient is able to ambulate on even surfaces greater than 10 feet, but is unable to walk 10 feet on uneven surfaces. A score of A, task attempted but not completed, would not be the most appropriate response. Let's look at example number 2. Mr. K has a driveway at home with an uneven surface. The physical therapist has been working on ambulation with him outside of the facility to prepare him for this task. Mr. K had a hip replacement and is now using a small-based quad cane with which to walk indoors. Upon walking outside on the uneven surface, he requires steadying assistance as he tends to be unsteady while using his device on the surface. What is the care rating level for Mr. K? The best response is supervision or touching assistance. That is what he requires in order to perform the activity safely, and he was able to go 10 feet. The next item is one step or curb, and it is defined as the ability to step over a curb or up and down one step. This item is not about wheeling up a ramp, and the patient can use whatever assistive devices he or she wishes. However, if the patient does not ambulate and is not expected to ambulate, rate this item as N. But if the patient does not ambulate at evaluation, but it is a goal, this item would be rated as dependent. The rating guide is on page 26 in your manual. A person who receives a score of 5, setup or cleanup assistance, would only need assistance before or after going up and down the one step. Perhaps the helper applies a prosthesis or a brace, or the helper applies shoes. But once the patient is standing at the step, he or she can go up and down it independently. Example number 1 is Mr. G, who is a bilateral amputee who has not used his prosthesis in more than 5 years. Due to his pulmonary status, he is satisfied with functioning at a wheelchair level. What is the care rating level for Mr. G? The best response is N, not applicable, because he is not a candidate for prosthetic training due to his pulmonary status, and he is satisfied with functioning at a wheelchair level. Example 2 is Mrs. P, who has orders for touchdown weight bearing on her right leg. She struggles with keeping her weight-bearing precautions on even surfaces, but is able to walk 5 feet with substantial or maximal assistance and a rolling walker. She approaches a single step, but is visibly concerned about attempting to go up or down one step. What is the care rating level for Mrs. P? The best answer would be dependent, because the therapist can infer from the patient's level of performance with walking on uneven surfaces that she is dependent for a single step due to her difficulty in maintaining her weight-bearing orders on uneven surfaces. Therefore, dependent would be the most appropriate score rather than an S, not attempted due to safety concerns, an N, not applicable, or a P, patient refused. The next item is 4 steps. It is defined as the ability to go up and down 4 steps with or without a rail once standing. The item is not about how quickly the patient accomplishes the task, and it is also about both directions, up and down, not just one direction. But the patient may use whatever assistive device he or she wishes. The rating guide is on page 27 in your manual. A person who receives a score of 4 or supervision or touching assistance would only need prompting and cueing during the activity. Perhaps there are concerns about safety when using an assistive device or the correct sequence of stepping up and down if there are weight-bearing restrictions. Let's look at example number 1. Mrs. Z has late-stage dementia and is being assessed for an appropriate functional maintenance program. She ambulates with a shuffle gait and requires only supervision or touching assistance. She can step up and down one step or curve with partial, moderate assistance. When she is presented with the task of going up and down 4 steps, she halts and refuses to step up. The therapist gives her verbal and visual prompts and places her hands on the handrail to induce memory. The patient becomes more agitated and begins to raise her voice. Therefore, the task is abandoned. What is the care rating level for Mrs. Z? The best response in this case would probably be S, not attempted due to safety concerns, because the patient became visibly agitated when the task of walking up and down 4 steps was presented to her. The therapist decided for safety reasons it would not be appropriate to attempt to try again. But the therapist is unable to infer from the other activities what her ability would be. In other words, even though she went up and down 1 step with partial or moderate assistance, it's unknown if she would be partial or moderate assistance with 4 steps, or perhaps substantial or maximal assistance, or even dependent. So that's why S is the most appropriate response. Example number 2 is Mrs. B. She has orders for 50% weight bearing on her right leg. She has 5 steps to get into her home. She wears 2 liters of oxygen at all times and has orders to keep her oxygen saturation above 90%. Using 2 handrails, she is able to go up 2 steps with substantial assistance from the helper. After 2 steps, her oxygen saturation drops to 86%. The helper waits 30 seconds and it does not come back up. Mrs. B begins to get anxious that she is not going to be able to get down. The helper abandons trying to go up any more steps and assists Mrs. B down the steps with substantial or maximum assistance. What is the care rating level for Mrs. B? In this example, the best response would be dependent. The therapist decides not to pursue completing the task for medical reasons. The patient's oxygen saturation was less than acceptable, and she was becoming more anxious, which would only increase her work of breathing. She was unable to go up and down 4 steps, and while part of this was related to her medical condition, 1 is the most appropriate score. The next item is 12 steps. It is defined as the ability to go up and down 12 steps with or without a rail once standing. Like the 4-step item, this item is not about how quickly the patient accomplishes the task, and it is about both directions, up and down. The rating guide is on page 28 of your manual. In determining whether to score a patient 2, substantial max assist, versus 3, partial moderate assist, the helper will need to think about the entire task, up and down the 12 steps, and usual performance, and then determine whether greater or less than 50% assistance was provided. Example number 1 is Mr. K. He is recovering from a fall where he fractured his right proximal humerus and his right patella. He is non-weight-bearing on his right arm and weight-bearing as tolerated on his right leg with a knee brace to keep his knee in full extension. He is able to ambulate with supervision or touching assistance with a quad cane for 125 feet. He is unable to step up on 1 step or curve without the helper providing all the effort to get him up on the step. What is the care rating level for Mr. K for 12 steps? The best response would be dependent. The patient is unable to go up and down 1 step or curve without total assistance of the helper. Therefore, it can be inferred that he would be dependent in the tasks of going up and down 12 steps and 4 steps. Example number 2 is Mr. O, who is recovering from a CVA with mild left hemiparesis. He wears an AFO on his left foot. He is unable to get the AFO on without assistance. But once the AFO is on, the patient can walk up and down 12 steps using a handrail on the right side on the way up and the way down. He stops after 4 steps and rests, and then continues up the steps. He rests for 2 minutes at the top of the steps before coming down. What is the care rating level for Mr. O? The best response is setup or cleanup assistance, number 5. Because the patient is able to go up and down the steps without physical assistance from the helper after his AFO is on properly. How long it takes him to go up and down, or how many rest breaks he takes is not a consideration in scoring this item. Now, let's take a patient example that involves more than one item and put it all together. Mr. R can go up 6 steps using a handrail. The first 2 she accomplished with verbal cues, and the last 4 she had one person helping 25%. She could not go up any more steps. On the way down the stairs, she required the same amount of assistance. So how do you rate her on 1 step, 4 steps, and 12 steps? The best response for 1 step is supervision or touching assistance, because the helper provides verbal cues on the way up and down. The best response for 4 steps is partial or moderate assistance, because the helper provides less than half the effort of getting up and down the steps. The best response for 12 steps is dependent, because the patient could not make it up and down 12 steps. All 3 must be graded, which is slightly different than the longest distance walked or wheeled, where only the maximum distance is scored. As this example shows, you don't have to test each item individually. Assess the patient on a flight of steps, which is typically 15, and then score their ability on each item based on their overall performance. Let's look at another example. Mrs. C is referred to PT. On evaluation, she is able to stand from the side of the bed but needs a helper to secure her chair and walker and give 25% of the physical effort to help her stand. Once standing, she can walk 50 feet with a forward-wheeled walker, but requires 33% cues for advancing the walker appropriately and taking an adequate step length. The patient is asked to step up 1 step or curb. She needs assistance from the helper to place her forward-wheeled walker up on the curb and to instruct her which legs to step up with first. Once her left foot is up on the step, she needs the helper to provide 75% assistance to give her enough power to lift her body and right leg up on the step. So what is Mrs. C's care rating level for sit to stand, mobility distance, and 1 step? The best answer for sit to stand is partial and moderate assistance, because the helper provides less than half the effort, but the patient needs physical assistance to get standing. The best response for mobility distance would be supervision or touching assistance, because the helper provides verbal cues, which are necessary to accomplish the mobility distance safely. The best response for going up and down 1 step is substantial or maximal assistance, because the helper provides more than half the effort to assist the patient in getting up onto the step. As always, remember that there are more clinical examples in the training manual. A few closing reminders. Every effort should be made to score all items with a 1 to 6 rating. Use your clinical judgment when assigning the scores. Perhaps there are some tasks that cannot be attempted because the patient is actually dependent in those areas. The correct response then would be dependent rather than not applicable or not attempted due to safety concerns. Even if a particular task or activity is not going to be the focus of your therapy program, you still must score those items. Why? Because these functional measures are not being looked at as individual items. The care item scores add up to a composite score of the patient's overall function. So if items are left not scored, then the patient's overall level of function in self-care and mobility will be lower than they should be. Now it's time to take the test. As stated earlier, all physical therapists will be required to complete this post-test, which tests your knowledge of the rating definitions, the alpha scores, and the item definitions. Some occupational therapists will be required to take this test, so check with your organization. Most therapists will take the test electronically. You will find the electronic link provided in your training manual. However, some companies may choose to test therapists using other methods, such as paper and pencil. So if you don't find a link in your manual, check with your managers. For those of you completing the electronic test, complete Section 3, Care Items Mobility Questions, which consists of 9 clinical scenarios and 21 total questions. You are required to score no less than an 80% to pass the test. You can use your training manual and any notes you took during this training to assist you. Your score will display on the last page after all questions have been completed, so you will know immediately how you did. You will be required to take the test again if you do not score 80%, but you can take the test as many times as you need to. This concludes the mobility training module. Good luck.